Burns School of Medicine. Thank you for joining us at our ECHO Long-Term Services and Supports COVID Preparation Series. I want to give a special thanks to our collaborators at the Hawaii Emergency Management Agency, the Healthcare Association of Hawaii, the Hawaii Association of Directors of Nursing, Hawaii Medical Directors Association, and Mountain Pacific Quality Health. We usually have a brief presentation and then we open it up for questions and discussions up till about 3 p.m. And we ask you to use the chat box to submit and to queue up your questions. So next slide, please. We have a schedule of upcoming sessions. Oh, so this is just the time frame. Next slide. Okay, this is the schedule of upcoming sessions. Today's session, we have COVID Conversations. This coming Friday, we're going to be talking about cohorting strategies for COVID-19. And after this, we'll be moving to twice-a-week sessions on Mondays and Wednesdays, with the next one being May 6th. And we're going to have our similar people from today, and we're going to talk about COVID symptom management. So, you know, hang in there. We're going to be talking a lot about advanced care planning and symptom management, and we'll get a lot of expertise. Next slide. Okay, we are offering CMEs, and nurses can use the CE for CE purposes as well. We can also offer certificates of attendance to all participants who complete an evaluation. If you haven't registered, we encourage you to do so right after this webinar. Evaluations can be found on our website under the Evaluations tab or by following the link in the chat box. So we ask you at this time to enter the names of all of the attendees in the chat box for our attendance purposes. And for those of you calling on the phone, just please, you can unmute yourself and tell us your name and we can write that down. Next slide. We want to give you a few announcements as well. This is a reminder that the folks from the UH Pacific Basin Telehealth Resource Center wants to provide assistance to help your facilities become telehealth ready. So please feel free to join them tomorrow, Thursday, April the 30th from 1 to 2 p.m. and the link is right there. Okay, and next slide, please. Okay, other announcements. Oh, that's the end of that. Okay, I'll just say the other announcements is that we are beginning to partner with the Hawaii State Health Center for Nursing. They were set up by the state legislature to build and empower the nursing workforce in Hawaii. They also created a wonderful repository of resources for all levels of nursing. And we will soon be posting the COVID-19 resources that they put together on our website as well. So you can also refer to those. They will also assist in backfilling some of the additional resources from our ECHO topics covered earlier. So please look out for new resources or updates within each section. And if Laura Reichardt is here, I just wanted to give a shout out to her and invite her to say anything if she wants to. We also recently updated our PPE resources for Hawaii page that was originally posted on April 13th, ECHO resources. So please refer to this and share this widely. We want everyone to be able to access enough PPEs. Okay, and so now we're going to introduce our speakers. Okay, so today's topic is COVID Conversations, Advanced Care Planning in the Geriatric Population Among COVID-19 Pandemic. We have Dr. Takeshi Uemura. He's an assistant professor at the Department of Geriatric Medicine. He's fellowship trained and board certified in both geriatric medicine and palliative medicine. We also have Jeanette Kojane on the line here as well. She's the executive director at Kakua Mau, Hawaii's Hospice and Palliative Care Organization. Jeanette can wave hi. And we also actually have another special guest with us today. We have Dr. Eric Chin, and he is calling from Yakima, Washington, where they are currently experiencing a surge of COVID in their nursing facilities, and he is having plenty of experience to share with us about these conversations. Lots of wisdom that we can glean. So without further ado, I'm going to open it up and take it away.
Okay. Yeah, so thank you, Aida, for the introduction. And then thank you, everyone, for having me today to talk about this important topic. I work for Department of Geriatrics, but also I work for hospice and then nursing homes. So I do a lot of advanced care planning as a geriatrician and as a practical care provider. Today, so I will briefly talk about advanced care planning in this COVID crisis. And also Janet will talk about POLST later. So next slide. So why is advanced care planning important during the COVID pandemic? As we all know, the COVID-19 is spreading in our community, even though I understand that the speed of spread is actually getting slower, luckily, in Hawaii, thanks to social distancing. As you've seen in the news and the articles, the geriatric population is at high risk for getting severely sick if they get COVID. And also importantly, the decline happens very quickly, sometimes even within hours. That means that we would not have enough time to discuss what kind of care they would want if we waited until the last minute. Also, you may have seen many news articles about the rapid spread of COVID in senior living settings. If it happens, it could spread rapidly and widely. Again, we would not have enough time to have discussion if that kind of rapid spread happens. Since the pandemic started, the care situation in hospitals and nursing homes changed as well, and no visitors allowed. They may die alone in the hospital, and staff will be very busy taking care of sick patients, and then they will not have enough time to update family, and then family can get frustrated and anxious. I'm hoping that we don't experience a big surge, but still we cannot be left unprepared. It is always good to be prepared, and it is important to have these conversations ahead of time. Next slide. So there are 3 things to know in preparing for COVID as shown in this slide. First, we need to make sure that we know who is the decision maker for the patient if they become sick and unable to speak for themselves. Second, we want to explore what's important to patient and what matters most. And these 2 things are actually the core elements of usual advanced care planning. But then as third, we want to know what kind of care patient would want to receive if they get COVID. And then this is the specific thing for COVID advanced care planning. Next. Advanced care planning specific to COVID is important to have, especially with patient who's high risk. So if you believe this patient would not benefit from doing CPR or transferring to ICU, it may make sense to have this kind of conversation. But don't take this as you should persuade patient for DNR or anything like that. I'm saying just having the conversation is important. And also, if patient's prognosis is less than 1 year, it may be a good idea to do COVID ACP. Some people use a surprise question to figure out if this patient has prognosis less than 1 year. Then I want to emphasize the importance of involving doctors and advanced practitioners in the process of advanced care planning, since this conversation should incorporate a lot of medical facts. Since COVID-19 can cause severe respiratory failure, it is important to address preference on hospitalization, intubation, and CPR. And advanced care planning is not about having patients choose whatever they want. It is a process between patients and providers to figure out what is best for the patient. Therefore, advanced care planning should incorporate not only patient's preference, but also medical facts and data, including current patient's condition, prognosis, and available care options. And in order to make sure the care plan will be conducted, POLST form will be very helpful. Next slide. Okay. Even though I said the advanced care planning should involve doctors and other advanced practitioners, that does not mean that there's nothing other people can do. Actually, there's a lot you can do for advanced care planning. First, you can review any existing documents in the chart. These include advanced directive and POLST. Then you can confirm with the patients or family and the contents of the documents. I will show you how to do it in a minute. And also, if there's no designated healthcare POA, you can help patient to choose one by asking who will be the best person to make medical decision for you if you become too sick to make them for yourself. Then if you're comfortable, you can help to explore patient's value by asking what's important to you. Finally, you can encourage patients to have advanced care planning with their providers by saying, having a conversation in advance with your doctor is important to make sure that your wishes will be honored. Next slide. So this slide shows you how to confirm the contents of the documents such as POLST. So you can read the script later, but basically you ask them, patients or family first, if they remember that they fill out the form, or if they remember the conversation they had when they fill out the form. And then if they say yes, you can ask them if they feel the same way. If they don't remember, you can remind them by saying, here's what you wrote in the document, and ask them if they feel the same way or differently. If they say they feel differently, you can respect that, and you can communicate with their provider to address that issue. Next slide. So this slide shows you a framework for having a conversation about COVID. So this is called Calmer, and it's developed by VitalTalk, an organization that provides specialized training on communication skills. Again, you can read the whole script later, but I can point out a couple of the important things. So first, you just check in with the patients and family by asking, how are you doing with all this? And see how they respond, and you can gauge their emotional temperature. Then you can throw a more specific question by asking, what have you been thinking about COVID and your situation? And then see, what they would say. After listening to them, you can ask if they have any preference on COVID care by asking, is there anything you want us to know if you get COVID? Next slide. Then you can provide more guidance to focus on two things. One is to make sure that they name proxy or agent. And the other is to make sure we know the patient's values. And if you're a doctor or advanced practitioner, and if you feel comfortable, you can make a recommendation by integrating patient's value and your medical expertise. For example, if patient said, I had good life and I am ready to go. I just want to spend time with my family as much as possible. And also, I do not want to suffer. Then you can say, is it okay if I make a recommendation? With knowing that spending time with your family and avoiding suffering are important, it would make sense that you stay here if you get COVID. And if you become very sick, we can arrange care here so that you don't need to go to the hospital. And we will not provide CPR so that you can have a peaceful death or something like that. And then you have to make sure the patient is okay with that by asking, how does it sound to you? Because we may be talking about life and death, this type of a conversation can provoke a strong emotional response. Instead of being scared of emotional response from patients and family, it is important to expect emotions from them and respond to it. Then you should document the conversation in a chart. If you're not a doctor, you need to communicate with their providers and ask for further guidance. If it's appropriate, you can also use POLST form to honor their wishes. Next. Okay. This slide shows you a conversation frame called CPR to specifically ask about CPR. It's a good name they came up with. So you can read this later, but the point is that you don't ask them, do you want to receive CPR? Instead, as described here, you ask them, what kind of person are you? So that you can focus more on their values rather than just a medical procedure. Next slide. And after conversation, patient may choose DNR or no hospital transfer. However, you should keep in mind what these mean in this COVID crisis. First, if you talk about DNR or do not intubate, you may want to reassure patient that their symptom will be taken care of. Since patient may feel anxious about suffering, and that anxiety may lead them to say, please do everything. So it is important to make sure that they'll be comfortable. And also, if they say, I don't want to go to hospital, you may want to make sure if it's even practical. Meaning, if the patient is in a nursing home, you check with the facility policy if the patient can stay there with COVID. And what is the procedure? And also, if they become seriously ill and dying, you may want to make sure the patient can be referred to hospice. But then you should know which hospice agency can accept COVID patient and how they handle the situation. If patients stay in nursing home and then is dying from COVID, will the family be allowed to visit? And if patient is at home, then have COVID, can that patient really stay home? Would it be safe? And who will be providing the care to patient? And then what's the procedure to make sure the infection control? So all these questions are very important to ask. And on the other hand, if patients choose food treatments, you may want to make sure that they understand what would happen in the hospital. And no visitors will be allowed, and they may die alone in the hospital and on the ventilator. So as you can see here, it is not only about choosing choice. It involves a lot of medical perspective and public health perspective. And it is why I am saying it is important to involve doctors in the process. Next. So in summary, advanced care planning conversations specific to COVID are important, especially for high-risk patients. COVID ACP needs to involve patient, agent, and doctors. CPR and intubation and hospital transfer need to be addressed in COVID advanced care planning, and POLST are helpful. And other IDT members can do a lot to facilitate COVID advanced care planning. Thank you. And Jeanette, you can take over. Oh, my email address, so you want to show quickly. So if you have any questions, you're welcome to send me email and ask questions. Thank you.
Thank you. So now we're going to have Jeanette Kojane from Kukua Mau present, and then after her presentation, we'll open up to questions.
Well, thank you very much for the invitation to talk today. I'm especially glad to be partnered with Dr. Uemura and to be talking about advanced care planning and POLST. I think, good. So we're going to be I'm going to review here the basics about POLST. I know some of you know about POLST, but there's often misunderstandings about what POLST does. So we wanted to be on an even footing about POLST. So next slide, please. So just to, for those of you that don't know Kukuamau yet, we are a statewide not-for-profit community benefit organization. We like to call ourselves a network to improve care. So we are a group of individuals and organizations that is committed to improving care for people with serious illness. We're actually going on our 20th year here in Hawaii, and all of you are welcome to get on our newsletter and participate in our activities. Our members are, there's a number of long-term care facilities like Arcadia, Kahalanui, and Pohainani, who are members, as well as hospitals and hospices and health plans. Really, we all are in this together as we strive to improve care. So we hope that you will, join us. Next. So one of the things that Kukuamau does is that we are the home of the POLST for Hawaii. And I am the POLST coordinator for Hawaii, which means I have to serve on national committees. But I also, along with the task force, we are very committed to maintaining the integrity of POLST. And we recognize, especially at this time, how important well-done POLSTs are to make sure that people are getting the right care at the right time and the right place, and that we're avoiding unwanted treatment. Next slide. So many of you have probably, you've probably seen that horrible green color. So remember, the POLST in Hawaii is that horrible green color. So it's easily findable. So a POLST provides direction for healthcare providers during serious illness. And different from a bracelet, which a lot of people remember, this allows shades of gray in the choices, which we're going to go through in just a minute. So a POLST is a portable medical order that transfers with the patient. It provides right now medical orders. As soon as a POLST is signed, that is the medical order for the patient. And as I said, it's brightly colored and standardized for the entire state of Hawaii. There is only one form that anybody should be using. Next. So the question always is, who would benefit from a POLST? It is people with chronic progressive illness, serious health conditions, people who are medically frail, a person who would have an inpatient DNR order, and as Takeshi said before, would you be surprised if this patient died within the next year? That is who is appropriate for POLST. So it's not appropriate for everyone, but for a lot of residents of long-term care, it is appropriate. Next slide, please. So it's really important to remember that you cannot mandate that your patients or the residents have a POLST. It can be encouraged, but it can never be mandated. That is against the law. However, once somebody has a POLST, honoring that form and honoring the wishes in the form is mandated. And it's also very important that all of you are clear that healthcare workers are protected from civil or criminal liability through the law. So happy to answer questions about it, and you can go on the Kukuamau website and read more about it, but you do have immunity in following the wishes of the POLST. Next slide. So just to briefly go through the elements of the POLST, and again, you can find this on the Kukuamau website. And again, we do like it to be on this green so that you can find it easily. It begins with the patient's last name, first name, date of birth, when it was completed. And if you want to, you can put the legally authorized representative on the back. However, the way that you are supposed to in Hawaii to designate the legally authorized representative, the healthcare power of attorney, is through an advance directive. Next. So the first part, part A, is talks about CPR. And you'll see in the red box, person has no pulse and is not breathing. So part A comes into play when someone has died. And I do want to say, as we are out in the community explaining this POLST as well as advanced directives to people, we find there's a lot of misunderstandings about when you do CPR. So just a heads up, as you're having these conversations, I've had quite a number of people try and talk me out of that CPR is done when somebody dies. So I find it quite interesting. I think it may be because a lot of people get their medical information from television, but this is something that we see more and more of. So heads up, that may be coming. So in part A, this is what kicks in. This is the part that's relevant when a person has no pulse and is no longer breathing. And the question is, are we going to attempt resuscitation or allow a natural death? These are conversations that need practice, and Dr. Takeshi went through quite a lot of excellent suggestions. This is one place where you don't say, should we do everything? The question is more, if your mother dies in her sleep, are we going to attempt resuscitation? Much different question, and we have to be very cognizant of how we present these questions. Okay, next part. So part B, this is if a person has a pulse and is still breathing. And you'll see there's 3 levels here. Comfort measures, limited interventions, and full treatment. So we are going to change, we were going to do this in the near future, not anymore, but we're going to change some of the wording on POLST to reflect national guidelines. So we are not going to say only anymore. We want people to understand that comfort measures are very important. Limited measures, people often talk about specialized or targeted interventions, and then full treatment. So these are 3 levels of treatment that are available for people. And again, we don't have time today to go through all of those, but just so you understand what those are. And again, I find that people often start with part B before they go to part A. Next slide. Next. So if you choose CPR, just keep hitting the buttons, you have to go to full treatment. That is the only option. But if you've chosen do not attempt resuscitation, all 3 of the options under Part B are available for you. Next. And finally, Part C, this is about artificially administered nutrition. Always appropriate, important to offer food and liquid by mouth if feasible and desired. But this is where patients can indicate their preferences. And I do find a lot of times you see a trial period, 2 weeks, 3 weeks, something like that. Okay, next. So the final part D, the last one on the front page, these are the really important signatures. If the patient still has capacity, the patient is signing for themselves. Oh, sorry. First, physician or an advanced practice registered nurse can sign. This is a medical order. It is a portable medical order, so it is not something that just anyone can do. And it's especially important that this is not completed by the patient, but rather completed by medical professionals. Patient or their legally authorized representative signs, and then there's a listing here of who those people are. Next. Next. So our recommendation is, again, keep it on the bright green form. You can make as many copies as you want, and I think it's valuable for families to make sure that they have it and they understand it. And then you need to keep it someplace visible. So it's important to say that, in a facility, I find people have a standard place where they leave, where they have the POLST. It can be in a record, but just very important, if EMS is called, then it's clear where the POLST is and it's given to EMS to transfer with them. If someone checks out, if someone is discharged from the facility, the POLST needs to go home with them. So think of the POLST as pinned to their chest. Next. So we made a little chart here to explain the differences with an advance directive and a POLST. So just quickly, advance directive is for anyone 18 and older. So yes, everybody listening to this call, you should have your own advance directive. Talks about wishes for future healthcare. It appoints your agent. It does not translate into actionable orders for EMS. And CPR and DNR are not addressed. That is different from a POLST. POLST is applicable for people at any age. It talks about current treatments. As I said, it is the right now medical order. You can note the legally authorized representative, but that is not how it's chosen. These are actionable orders, and it can be used as a DNR order and to indicate CPR wishes. Next. So if you think about advanced care planning as a continuum, as I said, we all need our own advance directives and think about who our people are and who would show up for us. But as soon as there's a diagnosis with serious or chronic progressive illness, that's when the conversations around POLST need to be started so that a POLST can be executed and people's treatment wishes can be honored. Next. So it's important to review the POLST if anything changes. So certainly in the time of COVID, it's good to think about that. And you know, if goals of care change, if therapies change, if someone has been in the hospital and is coming out and something may have changed, that is when you really need to review the POLST. And as I said before, this is really the best way to communicate wishes with EMS. Next. So think of this as not just a form, but as a way to have rich conversations, especially with families, to make treatment decisions and discuss goals of care. It's a complement to an advance directive, and it really can give far more depth and meaning to conversations than something that would be just an either or box. Okay, next. POLST can be changed. Anyone with capacity can revoke or change a POLST, and similarly, a legally authorized representative can change a POLST. We certainly hope that that change would be based on patient wishes or the condition of the patient. Next. Again, anyone can always change their mind on a POLST. We recommend drawing a line through it, writing void, and then executing a new document. Next. So think of the POLST conversations as a way to increase awareness and to have conversations like Takeshi talked about. This may be the time and a way to introduce palliative care or hospice care. And I really like thinking about what matters to me instead of what's the matter with me. Next. So again, I encourage you folks to join our mailing list, look at our website. That's where all the POLST materials live, as well as materials on CPR, tube feeding. We have translations of POLST in 10 different languages, so you can use that. And then in case you would like a longer presentation about POLST, let us know. This is very quick. And I recognize that there are a lot more questions that can come up, so just let us know about that. Next slide. So here's a picture of some of the things that are available. I want to give a shout out to Mountain Pacific. The first picture up there, a guide to advanced care planning, making life decisions. That's a 16-page booklet. They come in boxes of 800 and they're free for you. They are excellent, so let us know if you want some. Next. And then I pulled together some resources in the time of COVID, and I believe Dr. Wen put them up on the website as well. So we have a very robust web page with a lot of resources that we've been adding to over the last 5 weeks. So a lot of things that are mentioned today are up there. National POLST Office has a number of resources specifically about COVID and POLST for long-term care. CAPC has great resources that are all available for free right now, so that firewall has gone down. Ariadne Labs has an excellent communication guide, and I believe Takeshi provided a PDF as well for that. And then the California Coalition has 4 conversations guides. Next slide. And these are 4-page, very simple to understand, including one about ventilators as a decision aid for you to use. And these are free through May 30th, so download them now to be used. Okay, I think my last slide is there. Again, feel free to contact me as well and let me know how we can help.
All right, thank you so much, Dr. Uemura and Jeanette. And now it's time for questions. I got first up is Jacqueline Mock, right? If DNAR is chosen, is it okay to choose full treatment?
In fact, it is, and that is something that people ask all the time. So, I mean, I remember a guy who said, you know, if I die at home and I'm not going to be found for a long time, never mind, just let me go. But if I'm in a hospital, you guys can try all kinds of things. So, to be honest with you, when somebody clicks DNAR and full treatment, I think that warrants a conversation. That is a red flag to be having a conversation to make sure that the patient or that the loved ones, the agent understands what those different things mean. But according to the law, yes, you can do that. But again, I would say that really requires, that should lead to some good conversations about what all those options mean.
Okay, next question. What would you recommend for someone who had capacity when filling the POLST, but no longer has capacity at reevaluation?
So, you know, the POLST is valid. If there's nothing that's really changed, the POLST is still valid even if the person doesn't have capacity anymore. If a change needs to be made, then you need to have the legally authorized representative, the agent, on board, which is why everybody needs to have had those robust conversations with their agents so that they could still be speaking with the patient's voice if decisions need to be made. I will say that is one of those painful things I hear all the time, you know, that the patient didn't want to bother the family and the family says, I've never heard of this before. So, you know, especially, you know, right now we're in this period where maybe we have a little bit of time to be having good conversations. This is something that needs to be addressed. If family members don't know what the patient's wishes are, then they cannot honor them. So, and I think that that's really important, and it could be facilitated through social workers and nurses. It may be that the doctor needs to get involved, but those kind of quality conversations can be happening now.
Great. I have a question. So how can, you know, I think Dr. Uemura mentioned something about, you know, how can patients be with family when they're stuck in the nursing home and they're not allowed to have access?
Sorry, what was the question again? So patient is in nursing home and...
Yeah, how are they allowed to be with family? If their main wish, their dying wish is to die with their family and they're in a nursing home and they're not allowing visitors, right? So.
Yeah, and then I think that's the kind of things that you want to confirm with the facility, I guess. But I think the CDC guidelines said even patient has COVID in the compassionate situation, you know, you may allow, but still I think it depends on the facility. And then, you know, obviously you need to provide PPE to family. I think if the family is visiting the COVID infected patient. So again, I don't think there will be a simple answer, and that you may want to talk to also DOH to make sure they're okay. But Janet?
Yes, so by law, facilities need to allow family to say goodbye to patients who are at the very end of their life. And the regulations are that there would be a room someplace at the front of the facility where I think it's 2 family members at a time could come to say goodbye to the patient. Again, so that is at the very end. And that is still the law, and they actually gave me the number of who to call in case facilities aren't allowing that. So I'm pretty sure that that's still the law. But leading up to that time, before that person dies, this is really now our challenge for telehealth. And how can we get tablets? How can we use a phone? How can we have the people inside the facility facilitating those conversations? Because we know that for the families, this is just such a stressful time. I will tell you, we talk to a lot of social workers, and we actually are having weekly support groups, if you will, for social workers. And we've had discussions with nurses as well. The families are so stressed, and this is really important to try to be figuring out how can we do this. So we know that it's not necessarily easy, but you know, smartphones can be, you can be seeing a person, a tablet, you can have communication, and that can provide so much support to not only the patient, but also to the family. So I would really encourage people to be strategizing now about how to do that, and how to make those connections, because that is super important, and it's also going to help us as a community in the coming months and years when we think about the PTSD and the unaddressed grief and the issues. Like, we hear about it already. I think, Dr. Wen, that this is a really crucial thing where facilities can be super helpful, you know, and again, I wish it wasn't this way, but let's see what we can do to facilitate that.
Yes.
Can I have Eric to share his?
Yes, I'd love to hear his perspective. What do they do over there?
So, like Takashi said, and like Jenna said, the visiting is allowed for end-of-life situation. When a patient stops eating and drinking, when their prognosis is down to hours to days, that's when I notify my administrator and my director of nursing and tell them that, look, we don't have much time left, let's invite the family in. And some facilities has visitor rules, like 3 visitors a day and 1 hour at a time, and no overnight stay. And some are more relaxed. It really depends on the design of your facility. The major important thing is that once you invite visitor in, there could be a source of your COVID-19 carrier. So at all times, they still need to maintain 6 feet social distancing. So if you have a family of 10 people crowded into a room and they spread out into the hallways, then you're exposing your residents and your staffs being exposed to COVID-19. So number 1 is the 6 feet rule for social distancing. And number 2 is you also need to remind the family that, you know, the patient's dying of COVID-19, so it's very likely that the virus is in the air, or if the patient coughs, even with wearing N95s, if you have enough N95s to provide them, most likely you only will have surgical mask or even cloth mask. The infection control won't be 100% with that. Surgical mask, your filtration rate is only at 33%. N95 is 95%, and that's why they're called N95. But if you do have an outbreak, your N95 will be in short supply. You won't be supplying that to the family members. A CDC guideline does say that surgical masks are an acceptable alternative if you run out of your N95s. So families are most likely going to wear a surgical mask, and they walk in and they are at risk of being exposed. So if the family has pre-existing conditions, they definitely should be made aware of their risks of being exposed. And when they return home, I advise them to shower right away, throw their laundry into the laundry machine and wash it right away, so that they don't bring the virus into their home and infect their family members. So those are some practical tips that I can give for you.
Thank you.
And have you been able to using iPads or iPhones or things like that to help with the communication with the families?
You know, when
I mean, you perhaps.
Right. If patient is actively dying, most likely they will be delirious. So iPad.
No, I meant before. I thought the conversation was helping people along the way, not the active dying part.
Oh, okay. Before, definitely. each one of our facility has a designated person that will help families and even community doctors and specialists to set up virtual meetings. So that's definitely something that should be implemented. And most facilities probably already have something implemented because now most of the specialists, they have limited the number of visits that they're allowed to come into the clinic. So there should be some sort of virtual meeting capacity being established already in the facility.
Great. We have a question from Dr. Jeff Galbraith. Are any Hawaii skilled nursing facilities or ICF facilities currently committed to caring for COVID positive patients in-house?
I think Aida knows the answer. No.
Yeah, I think that not yet. I think where people are still struggling with even admitting COVID positive patients in-house. So that's being worked out right now.
I have to say, just from my local experience, we treated 150 residents with COVID-19 and 140 of them remaining in-house. We sent out very few, only 10 of the people who were full cold or who wanted a trial ventilation that was sent out to the hospital. We have only one small community hospital. We only have 300 beds. If we send 140 COVID-19 patients to the hospital, then it will completely overwhelm them and paralyze our healthcare system. Most of the healthcare system across the United States are close to capacity anyways at any given time. So, having events directive and having these early discussion regarding their POLST is very important. You're actually doing your local hospital a huge favor by reserving their capacity for people that have better chance of surviving it.
Yeah, so the moral of the story is be prepared because it's as hard as you like to try to keep people out, COVID positive people out, at some point, if there is a surge and it's in the community, it'll probably get into your facility. And we have to do the right thing by them and not necessarily send them to the hospital when they choose not to go. And so that's why it's going to be really important to come to the session about symptom management as well, because we really want to guarantee that we are able to honor those wishes if that time comes. And so really, whether you want to or not, I think we all have to be prepared to do that. As I think Dr. Chin has realized in, okay, so Jacqueline Mock, sometimes the determination of the end can stretch over a few days or a few even weeks, and it's heart-wrenching to determine when to allow the family in. Have you ever had that? What's your experience? How many days do they linger?
So so most of the people who die from the virus, either they have acute respiratory failure, and once their O2 sat drops below 90% on room air, then they go pretty quickly within a week. You can also tell by looking at nursing documentation how much fluid they're taking in, because a delirious person will probably pass from dehydration. That's not a bad way to go. It's like falling asleep, but as soon as their intake is below what they would need to sustain their maintenance level, the maintenance metabolic rate, then that's when you could see that they will probably pass away within a week. So a good formula that I use is the 3-2-1 rule. The first 10 kilograms of weight, you need 30 cc of fluid per hour per day for the first 10 kilogram, and 20 cc of fluid for the second 10 kilogram, and then each 10 kilograms after that is 10 cc per hour. So you're looking at least a 1.5 liter of fluid intake in a day. And if they start to fall below that, if they're down to 1 liter or 500 cc, then you know that the time is close.
Okay. So Dan Saltman mentioned something about Go Wish cards. I know there are many, many different conversation facilitators out there. Do you want to comment on, I don't know, what
Sure.
one is, or or if you
Yeah,
like?
so the Go Wish cards are great. I have one somewhere. We actually love using those, and they have an online version now. So you can go through, and basically it's different cards that help you be thinking, and I like it really as a tool to get people talking about what's important to them. And then, so the cards have all sorts of different things that you're thinking about, like be getting at peace with God, taking care of financial issues, saying goodbye to my loved ones, being, having fresh sheets. And you can kind of make piles about what's important and what's not, what are the top priorities. So that actually works well. I've used those with my own dad. There's some other tools that we like as well. We really like the Conversation Project materials. So if you go to the Kukuama website or go to the Conversation Project, they have this thing called the Starter Kit, which works you through various things around decision making. And then they actually have a tool, and Takeshi referred to it in this context as well, about thinking about your wishes at the time of COVID-19. So those are the good thing about the Go Wish cards is they're online and they're easy to access. There's actually a version in Chinese too. So for people who are trying to, who have residents who may have forgotten their English, or you want to play the cards in Chinese, they're out there. And, in terms of languages, I do want to say that Vital Talk has quite a number of resources in different languages, and Takeshi did the translation into Japanese. So there's other things out there.
Great.
And I can only say, my suggestion to people is start practicing these conversations. These are not easy. If you think they're easy, you have not practiced, because they are very hard. And this is one of my criticisms with wherever it is in the healthcare system. People have to recognize that advanced care planning conversations require a lot of work. You have to be super good at this. You have to listen. You have to have all your ducks in a row. I think that they should be reimbursed at a very high level and really prioritized. But no one is asking me to reorganize healthcare. But I think that so my suggestion is try inside of your facility, get 3 of you, come up with a scenario, daughter, patient, you, and try stuff out. And you can imagine, the daughter from California, or the daughter, the grumpy daughter, and just try and see what works, and use some of those scripts that Takeshi showed and the resources. You gotta practice and keep practicing. It is not easy.
Right. And that's the next question, right? How do you allay panic and fear when talking about COVID and reviewing POLST? And I imagine that some people will respond with panic or fear.
So I think I can answer the question. So actually, John, I have extra slides. So if you can come put up the slide. But so while he's doing so, again, so responding to emotion is the key whenever you do the conversation. And first you have to pay attention to so go to next slide. So this one. So I thought I wouldn't have enough time to mention, but the empathy is the key. So you have to expect the emotion and then show them your empathy. And then in order to show them, you have to say it. So they wouldn't get it if you don't say it. And then there is a way to say your empathy, and then that's called nurse statement. So it's on the right side of the slide, and then that's what Vital Talk teaches us. And then the U is understanding, so naming, so it sounds like, you're scared or you're anxious. And the understanding also, it must be hard to talk about this. And then respecting is like I've seen you coming to the hospital every single day, and it's hard to do. So I'm impressed, or something like that. And then supporting is about we're the specialists to provide comfort. So no worries, we'll take care of it or something. And the explorer is tell me more, or like what do you mean by that? And then by saying it, actually the patient, you see the patient will respond in different way, because we are trained, I think medical providers are trained not like almost ignore like emotion, and then to be objective. And that if you say something like this, they will feel like, oh, this person is different. And then you can rapidly create rapport, and then that helps to proceed the conversation. I hope I answered the question.
Thank you. And I love that nurse statement, right? It just goes to show you that, sometimes nurses can be more empathetic.
Yeah.
Right? Yeah.
I also want
Yeah,
to
and
share,
I do. Go ahead, Eric.
Okay.
Yeah.
I also want to share that, Takashi is very right on the point about expecting emotions and responding to emotions. A lot of times the family felt that their loved ones got the COVID-19 in a nursing home because of their fault, because they weren't able to care for them at home, because they weren't able to prevent an infection from getting to their loved ones. I would explain to them that this is not your fault. And then that opens up the next step, is to tell them that, your loved ones has been living with dementia, for example, and the most common ways for people living with dementia to pass is infection, and COVID-19 is really no different than any other infection that you would get. And then they would feel less inclined that, okay, because they would feel less guilty, and they would feel less inclined to send a patient to the hospital and ask for full code and full treatment out of guilt.
Thank you. That's a great reminder. Okay, so we are nearing the close of the hour. So before we close, I actually wanted to give you an opportunity to type in the chat box any topics that you would like to see in the future. So kind of as we're kind of closing up, you can type in whatever that comes to mind that you want to have us cover down the road. In addition, I also wanted to remind you that in order to get your CME or CE, please go to the webpage and complete the online evaluation form, and the link actually was at the top of this group chat as well, or in your email invitation. And feel free to put any comments in there as well. And then also, finally, there is, I noticed there's a lot of people who called in from their telephones, and we don't actually know who you are. And I don't know if you want to just unmute yourself and just say your name quickly so that we can record that. Or if there's a way from your phone to type in your name. I'll just give you that opportunity. Yes, this presentation is recorded, and it will be on the website as well as there are a ton of resources that have been downloaded onto the handouts, the downloaded handout site under each topic. So feel free to go back and pull those off and use them.
I want to say that if you discover other resources that should be included, please let us know. We have, as I said, we have a lot of good resources on the Kukuama website, and we are sharing on a pretty regular basis when we find new things. I think there's been a lot of great things created. No need to reinvent the wheel, and we love to share. I will say one of the things that is coming up a lot now that I see is the support for families and also support for providers. So mental health and supportive resources in that way. And I'm really glad Eric brought this up with the families, because we hear that and we don't even yet have any kind of a surge. So the guilt that the families are feeling is very real.
Yeah, and I want to say thank you to Eric for joining us. I know you're very busy. And actually, Eric will be coming back next session with me for symptom management. So, stay tuned.
Yes. Get ready. It's going to be heart-wrenching, I think. So,
Thank you.
yeah, thank you everybody for joining us. And thanks for all you guys who have typed in all your names and kept track over here. And still looking forward to your input. Thank you.